Emergency Medicine channel. Today in our series of video known as the EM Rapid, we'll be discussing about knee and ankle injuries. Before coming to the knee injuries as such, we'll discuss about the anatomy of the knee joint. So knee joint, it includes the femur, the tibia and the patella. Uh, Apart from these three bones, there are certain ligaments and there are the two menisci involved in this joint. So the ligaments are the medial and the lateral collateral ligaments, the anterior and posterior cruciate ligaments, and there is a medial meniscus and the lateral meniscus. So these structures form the knee joint, and you know that it's a hinge type of joint. So coming to the knee injuries. Regarding like what all we have to keep in mind while examining or taking the history of the knee injuries. So we have to determine the mechanism of the knee injury, any history of prior orthopedic or surgical procedures done. Then while evaluating or examining, we have to compare the contralateral normal joints. Always while examining, we have to compare it with the other normal joints. And also while doing all the ligament tests, the stress test, everything, we'll have to compare it with the contralateral joint. If the patient is mobile, if the patient's gait can be assessed, we'll have to assess the gait, and also we have to perform a straight leg raise test. If the patient can perform a straight leg raise test, we have to perform that and to assess the extensor complex. Then in the inspection part, we'll have to look for the ecchymosis, the swelling, any effusion, the masses, the patella. We have to look for the patellar location, its size, then any erythema, any evidence of the local trauma, any puncture wound, any sinuses. All these things should be examined. And we'll also have to look for any disparity in the length of the leg. So all these things are dealt in detail in the knee examination videos that has already been uploaded in our channel. So the knee examination, knee joint examination can be recapped from the video that has already been uploaded. While examining the knee joint, like a knee injury, we have to ask the patient to demonstrate the maximum range of active motion patient can perform. Then other important thing is we'll have to assess for the distal neurovascular function. And while examining, the dictum is to assess or examine the non-tender areas first and then move towards the area with maximum tenderness. And always palpate for the patella, the patellar facets, the proximal fibula, the femoral and tibial condyles for the presence of any tenderness or crepitus. And also any joint effusion, the joint line tenderness, any warmth, any altered sensation, all these things should be noted. And while examining the knee joint, an important part is we should not miss the popliteal region, because the knee joint, like any dislocation or any fractures, there is a high chance of going into vascular involvement, like any posterior dislocation and all can cause popliteal artery involvement, leading to hematoma, any pulsatile masses, all these things can happen. So popliteal space also should be looked for. And while examining the knee joint, with the knee joint in flexion, we have to palpate the medial and the lateral joint line and the medial and lateral collateral ligaments, because the tenderness at those locations, that is the possibility of a meniscal or a ligamentous injury. So the popliteal artery injuries, it has already been explained. The popliteal artery, there is high chance of injury, in posterior knee dislocation, any fractures to tibial plateau, femoral condyle fracture, any PCL injury and all. There is high chance of popliteal artery injury, and hence we have to check for that. And the importance is that there is less collateral circulation associated with this, and there's a high chance of the limb going into an amputation due to vascular compromise. So the neurovascular assessment in any knee injury is very important. And measure the distal pulses on ED admission, and after any manipulation, compare it with the pulse of the opposite side and document it frequently. And a diminished pulse raises a concern for vascular injury, and it should not be interpreted as due to vasospasm. Then other thing is the peroneal nerve injuries can result from severe ligamentous knee injuries or knee dislocation. And half of the fibular head fractures or avulsions are associated with peroneal nerve injury. So these are some of the like name tests that we use in assessing the ligaments of the knee and also the meniscal injury and all. All these like tests are detailedly described in our video of examination of the knee joint. I won't be describing how to perform these tests like in this video. Coming to the X-ray. So, what all are the commonly taken X-ray views? The normal anteroposterior view, the lateral view is taken, and like we have the oblique view that are helpful in detecting tibial plateau fracture. There's a tunnel or the intercondylar view that is helpful in identifying tibial spine fracture. There is a sunrise or the skyline or axial or tangential view that is helpful in detecting non-displaced vertical or marginal fractures of patella. Other thing is that X-ray, we may get a finding of like fat fluid levels that is suggestive of lipohemarthrosis and which is indicating intra-articular fracture. So that can be like seen in the lateral view of the knee in the X-ray. And other thing is like sometimes X-ray may be inconclusive and CT may be necessary to fully delineate the extent of the fractures, especially in tibial plateau fracture. So, like when to take X-ray, like a patient coming with a knee injury to your ED, and what make you like to take an X-ray. So we have certain rules that help us in guiding when a X-ray or a radiological imaging is indicated. So one is the Ottawa knee rule. So like if the patient age is more than 55 years, there is tenderness at the head of the fibula, isolated tenderness at of the patella. There is inability to flex knee beyond 90 degree, like to 90 degrees, if the patient is unable to flex the knee. Then if the patient can't bear weight, like at least like the patient can't walk 4 steps in the ED or after injury. So if these things are there, the patient like warrants a knee X-ray or a knee imaging. So other rule is a Pittsburgh knee rule. Here if there's a fall or blunt trauma mechanism, like if the history is not this, there is no need of knee radiography. If there's a fall or a blunt trauma mechanism and age is less than 12 or more than 50 years, we require a knee radiography. But if the patient age is not less than 12 years or not more than 50 years, and we'll have to check for if the patient is able to walk 4 steps in the ED, that is the patient can bear weight and walk, then there is no need for an X-ray. If the patient can't bear or the patient can't walk at least for 4 steps in the ED, then the knee X-ray should be taken. So that is the Pittsburgh knee rule. So coming to some of the knee injuries or the injuries in the like knee joint region. So one is the patellar fracture. So patellar fracture, it can be a transverse fracture, a comminuted fracture, or an avulsion type of fracture. So local tenderness will be there. There can be effusion and there will be local swelling. And we'll also have to check for the integrity of the extensor mechanism of knee in the patellar fracture. So patellar fracture, the mechanism is mostly from a direct blow or a forceful contraction of the quadriceps muscle. Treatment is non-displaced fracture with the intact extensor mechanism will require knee immobilizer, rest, analgesia, and follow-up radiographs is the treatment. If it is displaced for more than 3 mm or there is a articular incongruity of more than 2 mm or there is a extensor mechanism injury, then like all the above mentioned things, that is knee immobilizer, analgesia, rest, along with that an open like reduction internal fixation may be required, and we'll have to refer the patient to an orthopedician or a center with such facility. If it is a severe comminuted fracture, then surgical debridement of the small fragments along with the extensor mechanism repair will be the treatment. And if it's an open fracture, Then like any other open fracture, we have to go for irrigation. We have to like go for the triple antibiotic coverage, and if it is contaminated, we have to go for a tetanus like immunization. All these things should be taken care of, and it will require surgical debridement and fixation. So next is a femoral condyle fracture. So femoral condyle fracture occurs when there is a fall with axial loading and the knee is in a valgus, varus or rotational position, or it can occur due to a blow to the femoral condyle. So here also the management is, if it is an incomplete or a non-displaced fracture, then it requires knee immobilizer, analgesics and referral to an orthopedic center. But if it's a displaced fracture or fracture with any joint incongruity, it will require an open reduction internal fixation. Again, an orthopedic consult. And here also other things like the analgesia, all those measures should be provided. So in a femoral condyle fracture, the examination, there will be pain, swelling, deformity, then there can be shortening and an inability to ambulate. The popliteal artery involvement is likely, so we'll have to take care in the vascular examination. And associated with the femoral condyle injury, there can be hip dislocation or fracture and damage to the quadriceps apparatus. Then, in a femoral condyle injury, there are complications like a DVT, fat embolism, and delayed union or malunion can happen, and also there is a chance of subsequent osteoarthritis. Next is the tibial spine and tuberosity fracture. So here the mechanism is a force directed against the flexed proximal tibia in an anterior or posterior direction. That is the tibia is in a flexed position, and the force coming in an anterior or posterior direction can cause the injury. So here, if it's an incomplete or non-displaced fracture, it will require immobilization and full extension or the knee immobilizer with the orthopedic referral in 2 to 7 days. And if it is a complete or displaced fracture, again, it requires an open reduction and internal fixation. Here, the examination again shows pain, swollen knee, then there can be hemarthrosis. Patient can't extend the knee fully, and there will be a positive Latchman test. Coming to the tibial plateau fracture. Tibial plateau fracture, valgus or varus forces combined with axial loading drives the femoral condyle into the tibia, leading to the tibial plateau fracture. That is when there can be fall or the leg of a person is hit by the car bumper and all. These fracture can happen. Here again, non-displaced lateral fracture, knee immobilizer with a non-weight bearing and an orthopedic referral. But if it is a depression of the articular surface, it will require open reduction and internal fixation. The ACL and medial collateral ligament injuries are associated with a lateral plateau fracture, whereas posterior cruciate ligament and lateral collateral ligament, PCL and lateral collateral ligament injuries are associated with the medial plateau fracture. So coming to the ligament injuries. So here we have the medial collateral and lateral collateral ligament injury. So the medial stabilizers of the knee are tested by applying a valgus stress to the knee at 0 degrees and in approximately 30 degrees of flexion to determine the integrity of the medial capsular and ligamentous structure. So it is a median ligaments are stressed by the valgus stress test. The medial collateral ligament supplies a majority of restraint to valgus deformities of the knee in all stages of flexion. And a varus force is then applied to the lateral aspect of the knee to ascertain the integrity of the lateral structures. So medial structures are like the integrity is tested by the valgus test, and the lateral ligaments integrity are tested by the varus test. The history of the ACL injury is like the typical history, along with the presence of a traumatic effusion, is very suggestive of the ACL disruption. And the diagnosis is made using Latchman test, anterior droid test, and the pivot shift test. Next is the PCL injury or the posterior cruciate ligament injury. So the posterior cruciate ligament provides the initial resistance to the posterior translation at all angles of flexion of the knee joint. Deficit of this ligament is identified by the posterior drawer test or the and the sac test or the sac sign. So the treatments of the ligament injuries. So injuries involving a single ligament with a minor strain can be managed with a simple like brace, hinged brace, ice packs, NSAIDs for analgesia, limb elevation, and ambulation as soon as the patient can tolerate the pain. And a complete rupture of an isolated ligament can initially be treated conservatively with straight leg quadriceps strengthening, range of motion exercises, and functional bracing. And if arthrocentesis may be of therapeutic benefits if the patient has a large intense effusion of the knee joint. Coming to the meniscal injury. So any cutting, squatting, or twisting maneuvers can cause injury to the menisci. Patient experience painful locking of the knee joint on either flexion or extension. So menisci are basically the like a pad of cartilage that provide the cushioning to the joint. So there will be locking of the knee like feeling if there's a meniscal injury. And the signs of a meniscal tear include effusions that occur after activity, a sensation of popping, clicking, or snapping, a feeling of instability in the joint, especially with activity, and tenderness in the anterior joint space after excessive activity. Definitive diagnosis can be made by MRI or arthroscopy, and arthroscopy like it includes like both a diagnostic and therapeutic effects, because arthroscopy can be like for a diagnosis, and it can also be used for a treatment like a partial meniscectomy or a meniscal repair can be done arthroscopically. So the treatment like is surgical treatment if there is a significant meniscal injury. Next is the knee dislocation. The knee dislocation commonly seen as an anterior dislocation, but there can be posterior, lateral, medial, and rotatory dislocations. So, due to severe ligamentous damage, spontaneous reduction mostly occurs in a knee dislocation. That is about 50% patients will have a spontaneous reduction after a knee dislocation. A severely injured knee that is unstable in multiple directions raises the suspicion of a spontaneously reduced knee dislocation. There is high incidence of associated complications, including the popliteal artery injury and peroneal nerve injury, mostly with the posterior dislocations, and there can be also associated ligamentous and meniscal injuries in the dislocation. So this is a picture showing the anterior dislocation, the posterior dislocation, and the lateral dislocation. So basically we term it anterior and posterior based on the displacement of the tibia. That is, the tibia will be pushed anteriorly, then it's an anterior dislocation. Tibia pushed posteriorly, it will be a posterior dislocation. So the reduction of knee joint dislocation is important. We have to apply longitudinal tractions for the reduction. Like any other closed reduction, it should be done under adequate procedural sedation and analgesia after explaining the complications and getting consent from the patient. So like important thing is that post the dislocation, we'll have to document the neurovascular status prior to the reduction and also post procedure, because it is closely associated with the peroneal nerves and the popliteal artery. So there is chance of neurovascular compromise. So we have to go for the neurovascular assessment and documentation. And after the reduction, we have to splint the lower extremity with the knee in 20 degrees of flexion, and that serial vascular assessment should also be possible while splinting. And after reduction, after splinting, we'll have to go for a repeat imaging, and the patient should be hospitalized. Serial neurovascular examination as well as ankle brachial index should be checked in patients with a knee joint dislocation, and patients with distal pulses present before and after reduction, and ankle brachial index of more than 0.9 can be observed with serial neurovascular check. But if the patient has asymmetrical distal pulses or the ankle brachial index is less than 0.9, or there is any other clinical concern for a vascular injury, including any features of ischemia, hemorrhage, or an expanding hematoma, then we'll have to get a CT angiogram or angiography to look for any vascular involvement. Next is a patellar dislocation. Patellar dislocation usually occurs from a twisting injury to extended knee. Patella is displaced commonly laterally over the lateral condyle, and it results in deformity of the knee and also pain. So reduction is done after adequate analgesia and the sedation, where it is done by flexing the hip and then gently extending the knee, and then the patella is pushed back into the place. It is patella is guided back into its location. So we'll have to flex the hip and gently extend the knee and simultaneously guide the patella to its location. And post procedure also we'll have to obtain radiograph, and we'll have to exclude any fracture. And then the knee immobilizer should be placed after reduction. And the patient, like if the patient has pain on moving and all, we should provide crutches. And partial weight bearing and straight leg raising exercises to strengthen the quadriceps should be instructed to the patient, and for patient should be followed up after 1 week. So that was regarding the knee injuries. Now coming to the ankle injury. So again here, like the ankle injuries, commonly injuries are associated with the ligaments of the ankle. So the ligaments, there are like medial and lateral ligaments structures are there. So laterally there is the posterior talofibular, anterior talofibular, and the calcaneofibular ligaments. You can see that the fibula is attached to the calcaneum and the talus bones. So there is a anterior and posterior talofibular ligament, and there is a calcaneofibular ligament. Medially, there is a deltoid ligament. So you can see the deltoid ligament. Deltoid ligament has a deep and superficial components. So the deep component include the posterior tibiotalar ligament and anterior tibiotalar ligament, and the superficial components are the tibiocalcaneal and tibionavicular ligament. So here, medially, the tibia is connected to talus, that is the tibiotalar ligament, anterior and posterior. Then tibia is attached to the calcaneum, that is tibiocalcaneal ligament, and also naviculum, that is tibionavicular ligament. Then in ankle injuries, what are the history and the clinical features that we should check for? So again, the mechanism of injury, the timing of injury is important. Then there can be like certain tests and certain signs that point towards certain injuries. So there is a Masonov fracture where when there is a tenderness of the fibular head or the proximal fibular shaft. So we have to suspect that when there is a tenderness of fibular head or proximal fibular shaft. Then active and passive plantar flexion, dorsiflexion, and full range of movement should be checked for. And like when there is a peroneal tendon injury, there will be pain and on eversion. Eversion will be painful, and it mostly occurs with a forced dorsiflexion. And there is also an anterior drawer test for ankle joint as well. So it is used in assessing an anterior talofibular ligament. So basically, the heel is held and the by one hand, and the ankle joint is moved anteriorly, pushed anteriorly. If it is moving for more than 10 to 15 degrees, then we have to suspect the like anterior talofibular ligament injury. That is the anterior drawer test. Then one thing is this cross leg test. Here the patient will sit with the leg crossed over, and the fibula will be exerting a pressure onto the like tibia. And when there is like pain on cross leg test, it is suggestive of a syndesmosis injury. And again, when there is a squeeze test, that is we'll squeeze the calf muscle region, and when there is pain over that region, it is suggestive of a syndesmosis injury. And other thing is the inversion stress test, which is showing a calcaneofibular ligament instability. And we'll have to also check for the Achilles tendon integrity, that is the continuity of the Achilles tendon we'll have to check for. And also the neurovascular examination, that is any local sensory or motor weakness, any vascular deficits, that is we'll have to check for the dorsalis pedis, and the posterior tibial artery pulsation should be checked for, and all these neurovascular examination should also be done. So here again, if the patient is coming with a suspected ankle injury, we'll have to get an X-ray done. So when should we get the X-ray? So it is based on the Ottawa ankle rule. So the X-ray of an ankle is required that is in an ankle injury, we may require an X-ray of ankle and we may require the X-ray of a foot. So X-ray of ankle is required if the patient has pain in the malleolar zone and the findings like suggestive are bone tenderness at the posterior edge or tip of the lateral malleolus, or any bony tenderness at the posterior edge or tip of the medial malleolus. So if there is a medial malleolar or lateral malleolar tip tenderness, and the patient has inability to bear weight or patient has inability to walk, we will have to get the ankle X-ray. And similarly, a foot X-ray is warranted if there is a tenderness at the base of the fifth metatarsal or there is a tenderness at the navicular bone. If these area there is a tenderness, and the patient can't bear weight or the patient has inability to walk, then we'll have to get a foot X-ray. So this is the imaging based on the Ottawa ankle rule. So the X-rays common views include the anteroposterior, the lateral and the 15-degree internal oblique views. And again, ultrasound also has a role in the ankle injuries. Ultrasound helps us in looking for the Achilles tendon rupture. If the continuation of the Achilles tendon, we can look for, and it helps us in identifying the Achilles tendon rupture and also an ankle fracture. The continuity of the bony cortex can be checked with the ultrasound, and we can help use the ultrasound in diagnosing Achilles tendon rupture and the ankle fracture. Then the other the imaging modalities are the CT and MRI, which help us in detecting like any fractures that are unnoticed in the X-ray or any ligamentous injury can be identified from the MRI. So these are the imaging that we use in ankle injury diagnosis. So coming to tendon injuries. So the tendon injuries associated with the ankle joint are the peroneal tendon injuries and the Achilles tendon rupture. So the peroneal tendon injuries occur in hyperdorsiflexion. There will be ecchymosis or tenderness over the posterior edge of lateral malleolus. The Achilles tendon rupture occurs in sudden plantar flexion, and we can palpate for the defects. And there is a test known as the Thompson's test when the patient is on prone position and there is absence of plantar flexion on squeezing the calf of affected side, then it is suggestive of a Achilles tendon rupture. Here again, ultrasound helps in diagnosis, and the ultimate treatment is a surgical repair of the tendon. But again, like the analgesia, rest, all these things we have to provide from our ED. Next is a ligament injury. So common ankle sprain, it occurs in lateral ankle and it occurs due to an inversion injury. So there are three grading of the ligament injuries. That is grade 1 when there is no tearing of the ligament with minimal functional loss. Grade 2 is partial tear with some loss of functional ability. Grade 3 is complete tear with loss of function, bruising, pain and swelling. So treatment is based on the price protocol. That is, we have to provide the protection, rest, ice, compression and elevation. Initial 24 hours, we have to provide these things. Then motion and strengthening exercises should be start within 48 to 72 hours. After that, post 72 hours, endurance training focused on specific sports should be started. Next, coming to the ankle dislocations. So common ankle dislocations are the anterior and the posterior, and commonest is posterior dislocation. So it occurs when there's a backward force on a plantar flexed foot. Then in the dislocation, we have to check for neurovascular compromise. And if there is a neurovascular compromise, we have to go for immediate reduction with adequate analgesia and procedural sedation. And after reduction, we have to immobilize, and we have to check for the neurovascular status post reduction also. And if the reduction fails in if the closed reduction fails in the ED, then open techniques should be used. Next is the fractures. Fractures commonly seen in the ankle region are the unimalleolar, that is fracture of either the lateral malleoli or the medial malleoli. Then bimalleolar, that is fractures including both medial and lateral malleoli, and trimalleolar, that is the fracture involving lateral, medial, and posterior malleoli. So here you can see the first figure is a lateral malleoli and medial malleoli fractures we can see, and that is the APV. And the lateral view of, we can see that the posterior malleoli is also involved. So it is a trimalleolar fracture. Here again, we can know that it is a bimalleolar fracture involving medial and lateral malleoli. But again, a lateral X-ray should be taken to rule out the posterior malleolar involvement. So treatment, like the fractures, like any other region fractures, we have to restore the anatomical relationship. So if it is like not displaced and all, we can go for immobilization with cast, and if required, we can go for surgical repair and casting. If it is comminuted fracture and all, there is chance of complications like compartment syndrome, fat embolism, and poor healing. And like there will be a time gap between the patient presenting 2ED and the surgical repair. And till the definitive treatment, patient should be provided with posterior splinting and stirrup, adequate analgesia, and non-weight bearing. So from ED setup, we'll have to provide adequate analgesia, immobilization, and splinting should be provided. Open fractures, again, like any other area, we have to go for irrigation. We have to cover the area with gauzes, that is saline wetted gauzes after adequate irrigation. Then the fracture area should be splinted, which helps in reducing the bleeding. And also patient should be put on triple antibiotic coverage, including cefazolin, metronidazole, and aminoglycosides. And also tetanus immunization should be given to the patient if there is any contaminant. So this table gives you an idea about like the orthopedic consultations, whether there's a need for an immediate ortho consultation or like ortho consultation at a later time, maybe after 1 week, like that. So immediate ortho consultation is warranted when there is a like all cases of open fractures, all fracture dislocations, all dislocations, all trimalleolar fractures, all bimalleolar fractures, and any unstable unimalleolar fractures, and any Masonov fractures. And like maybe like at a later time after 1 week, we can give an ortho review when there's a potentially unstable sprain. So these are the ankle injuries that warrant a ortho consultation.